Okay, my talk will be about slit lamp. As all we know, slit lamp, you get a source of light here. Light will pass through. Some lenses will condense this light to be reflected in a mirror. This mirror will direct the light to the patient's eye. Then through the microscope, the doctor will observe a magnified image of the patient. The phenomena of a slit lamp depends on light scatter. In order to see anything, you need light to be projected on that thing, then it reflects back to you. I have here a model of this. What's happened with the slit lamp? This is the model of the eyeball. Here you can see the cornea, and this is the lens. If we throw a light through these structures, as you can see here, this light will make a section in the cornea. This is the anterior surface of the cornea, this is the stroma, and this is the posterior surface of the cornea. Now I'm taking the lens out. As you can see here, light reaches to the iris. So this distance is the anterior chamber. This is the source of my illumination. You can make a section in any part you want in the cornea. I'm taking the cornea out, putting the lens in place. Now this is the section in the lens. This is the anterior surface of the lens, and behind this is the posterior surface of the lens. Just I'm dimming the light of the room to see things better. This is the equator of the lens, and this is the section of the layers of the lens. Now the cornea back in place. So we have here, this is the section in the cornea, and here we got light in the lens. So in between, this is the anterior chamber. So slit lamp can make a section in the living human eye. We can make section in any part we want in the cornea or in the lens, and we can see thickness of a tissue or distances between one structure and the next structure. So this is the idea of the slit lamp. Being we depend on light scatter, so we need to be, the sensitivity of the observer should be very high, the sensitivity of the retina. And we all know if we stayed in a dark room for enough time, the sensitivity of our retina will be high. That's why the examination of the slit lamp should be in a dark room, in a way to increase our sensitivity of our retina, and also to get a higher contrast between the structures we see, so we can see better. If we illuminate the room maximum, we will not see anything projected on the screen, but if we get the room dark, we will see better. So always we need to examine a patient in a dark room. Again, avoid using any fan in the room. If there is a fan, there will be a rapid evaporation of the tears, and the patient cannot open the eye nicely all the time. So avoid air currents. Now, to use the slit lamp for anterior segment examination, we start by diffuse illumination. We open the slit beam to the maximum. So in this drawing, we get here the source of light. We open the shutter to illuminate the whole cornea, and this is the microscope where the observer is observing. We start by having a very low magnification. In a slit lamp in general, if you get a higher magnification, the problems to observe things will be more difficult. Remember in the pathology or in the histology, when we were back at undergraduate, we used to identify the tissue we are examining by holding the piece of a slide and using the eyepiece of the microscope to get a very low magnification to identify this is the liver, this is the kidney or what. Then we go to higher magnification. The same will be here. We should start always the slit lamp with low magnification. If you suspect anything in one location, you can increase the magnification. But all the time we are using a low magnification. Now this is a general impression. I want to ask you, what do you see here on this slide? What do you observe here? What? See some dots here. I cannot tell it's sclerotic precipitates or this is in the cornea. And I can see here an edge. So it looks that we have a contact lens and there is some dots here. These dots can be in the lens, can be in the cornea, can be anywhere. I cannot tell. What you observe here? It's a haziness of the cornea. I don't see through it. I don't see the pupil nicely. I don't see the iris nicely. Maybe in the periphery it's less, but in this central part or most of the cornea, it's hazy. This is only the comment I can tell. I cannot tell anything more than that. Now, after having diffused light with low magnification, then we start to use a direct focal illumination. We narrow the light source to focus on certain point. This is a widely open section of the light. As you can see here in this part, this is the anterior surface of the cornea, and this is a section in the cornea. So this is the epithelial side and this is the endothelial side. Again here, this is a wide section. You get anterior surface of the cornea, and this is a section in the stroma itself. So you notice here these dots, these are sclerotic precipitates on the back surface of the cornea. But these dots here, you cannot tell whether these dots are in the epithelium or maybe they are in the stroma or they are at the back of the cornea. You can never tell. You need to have a very narrow section like this part to say that these dots are in the back of the cornea. What is the normal appearance of the cornea? If I make a section like this, normally we get an interface here between the tears and the epithelium. So we will see a bright light here. Then the epithelium itself is translucent. It's just a dark zone. We don't see the epithelium. Then another bright light here. This is the Bowman's membrane. So if you try it clinically, you make a very narrow section. You make first a good focus of the eye pieces. You try to use one eye, then focus one eye piece, then convert the other eye and focus the second eye piece, then open both eyes. Now you get a very clear image, and concentrate on this part of the slit lamp. You will see it as double line. Bright line, black zone, bright line. The first bright light here is the reflection between the tears and the epithelium. Epithelium itself, it's opaque, it's black, we don't see it. There is nothing in the pathology called opacified epithelium. So epithelium is always black. Then you get another bright light, this is the Bowman's membrane. Then you get the stroma here, and at the end, the back surface, you see both the desmus membrane and the endothelium. So this is the section we are going to see. Then after that, this is the depth of the anterior chamber. This is the light on the iris and the light on the anterior surface of the lens. Here, this is the section in the cornea. We don't see these two lines because this image is not that focused, but clinically you can do it. Back here we get the endothelium, anterior chamber, iris. What do you see in this image? I would say this looks area as a whole a little bit hazy. Now this is section in the cornea. This is the central part of the cornea, and this is the periphery of the cornea. We all know that the cornea should be thin in the center and thick in the periphery. As you notice here, it looks all over thick. So there is either increased thickness in the central part or reduced thickness in the periphery. But it's not normal. The whole section is almost of the same thickness. And as you notice here, you can see some reflection here. There is some light here, another light here. So what we have here, a hazy cornea and equal thickness in the slit part between the center and periphery and this elevation. So actually we are seeing a case of a corneal edema, because here the thickness is increased and even the edema gets forward toward the epithelium. You know that the epithelium is a barrier preventing the passage of aqueous, either from out in or from in out. That's why fluids accumulating in the stroma accumulate under the epithelium, and the epithelium start to be elevated, and we say we get a large bully. One of the things that I see with my young residents, they tell me we get a patient having an epithelial edema but not stroma. This is something wouldn't happen, because edema starts in the deep layers and start to move forward toward the epithelium. So I will say to the resident, no, it's both. The only condition where you're going to have an epithelial edema without stroma, if a patient were having a contact lens and you get some toxic effect from the contact lens on the epithelium. So this damage is only superficial. But apart of that, always start with the back and then moving forward. Now this another example. What do you see here? What do you say? I would say here pupil is oval. You get some iridectomy here, and the media is hazy. That's all. Okay, hazy media can be due to edema in the cornea or opacity. Clinically, how would you differentiate between corneal scar and corneal edema? Both will make the cornea hazy. I cannot see through the cornea. How to differentiate? The thickness. If I make a section and I find that the cornea is thick, then this is edema. If the cornea is normal thickness or thinner, this is scar tissue. To tell that the cornea is thick, you can do one of two things. Either compare between the center and the periphery, or if the cornea as a whole from the center and to the periphery all is thick, then compare one eye to the another eye, second eye. So this hazy cornea most probably could be to some edema. Again, what do you see here? It's a hazy cornea, and it's marked thickness of the cornea, and you can see here the double line. One of the things I want to draw your attention here, this back surface, we call this folds in the isthmus membrane. You see it very common if some patient underwent a cataract surgery and the manipulation during the surgery were rough and away. Then you see these folds in the isthmus membrane. They are there for some time, then they disappear. Why is that? The idea is whenever you get edema, the whole corneal thickness will move in a posterior direction. The anterior surface is almost stable, but the posterior surface, the thickness will increase in a posterior direction. Now, this surface, the back surface, if there was no edema, it will be stretched at one level. if there is edema, the back surface will be stretched in a second, more posterior location. If you get this point at the limbus to the other point at the limbus fixed, and you get a certain length of tissue, if you push the things inside, then this surface should be folded. Imagine you get a thread attached to this point and to the other point here, and it is stretched. If you push this thread inward, it must be having some folds to cover this shorter area. That's why you get folds of the dismus membrane. When the edema subsides, the surface goes forward to its normal position and the dismus folds will disappear. This is the explanation why we have these folds in the dismus membrane. What do you notice here in this picture? We noted that this section here, you get increased thickness in this part. So it's localized edema of this part of the cornea. If you want to know the extent, how laterally this is extending, then you have to move your section in these different parts. What you notice in this image, so you notice this part is thin. If you see here the normal reflection on the surface, you will say that the epithelium is intact. If not, then the epithelium is not intact. So if you are in the outpatient clinic and you don't have fluorescein and you want to tell if this is an ulcer or not, this part looks thin. Regularly we put a stain and see is it stained or not, but if you don't have fluorescein, you just make the section very narrow and see the reflection anterior surface between the tear film and epithelium, and another light, the Bowman's. If you see these two, then you get an intact epithelium. So what you told me now here, you can tell, when you make a section, you can tell if this tissue is thicker or thinner. Now I want you to see these images. We notice here there is some opacity of the cornea. It's vascularized here. First, I want to ask you, these vessels are superficial or deep vascularization? So yes, it's superficial. Why you said superficial? So it's reaching to the limbus. You can follow them on the sclera and straight. Actually, superficial vessels are not straight. The deep one, the interstitial one, are the one to be straight, simply because the intermediate one in the middle of the stroma are compact with the stroma. So they just find their way and move forward. But on the surface, they are not straight. They can be wavy and they can branch. As you notice here, we have branching. So this is superficial vascularization. Because we can follow them to the limbus on the surface of the sclera, they are not interrupted, and again because they are wavy and branching. So this is superficial vascularization. Now we notice the section here. You see the thickness and you see the thickness. So this part is thinner, okay? And notice the curvature and notice the curvature. So this is at least as curved at this part or slightly forward. So we get a thinning of this area of the cornea and it's slightly bulging. Now we see this image. What do you notice here in the section and this part? It seems we have a lesion here, something different, and the section here, thickness, and this thickness here. So this part is thicker or thinner? It's thinner. We get thinning of the cornea in this part. In this drawing, this is what we see normally. Two reflective lines in between epithelium, and this is the stroma and this is the endothelium. If you get a foreign body, for example, you will say this foreign body is superficial or is in the middle or is in the deep layers of the stroma, but you have to make a section. Now, this is the case, you see here, we get some haziness here. Notice this part. What do you see here? There is a line in the stroma. What is the level of this line? Maybe مثلا say 1/3 to 2/3. It's superficial 1/3. Now we start to make section in different parts. Here, this is another to the nasal side, another section, and you notice the line, and this is another section and another location. So by making section in different parts, we can tell exactly the level of the opacity. Is it superficial all over? Here we'll say it looks be superficial. If you make it here, it's lamellar, but still lamellar, like it's getting a little bit deeper at this location. Here again it's almost in the middle. Again it's in the middle. In this slide, what do you see? I see here haziness starting from the epithelium side and ending at the endothelial side. So this is the scar tissue extending all the way. So I will say this opacity has started superficially and ends deep. So this is the value of a slit lamp. Okay. Would you put the light of the room off, please? What do you see by in this image? It's a keratoplasty, I agree. You can see a ring here and you get the stitches all over. Yes. First notice the section in the cornea here and here and here. What do you notice here? The thickness here compared to this part. It looks that the lower part is thicker. Then you see these are folds in the desmus membrane. You can see them here in a section and you can see them here linear. Now this is the light on the iris, this is the light on the lens, and this is the light on the iris. So the anterior chamber, we have an iris corneal touch. Here there is no lens corneal touch. There is a tiny space between the anterior surface of the lens and the back of the cornea. So this is not total flat anterior chamber, it's a shallow essay. Okay? Now I want you to see this slide. What do you see here? First section in the cornea, is it equal all over? Is it thinner in the center? Is it what? What do you see? I want to compare the periphery with the center. Maybe the central is a little bit thinner, okay? So, and this is normal. Then this is the light on the iris. And here we get the light on the iris. So this part represents the anterior chamber depth. What about the anterior chamber depth in the upper part compared to that in the lower part? It's irregular. It's very shallow or no anterior chamber lower down. Now, we notice that we have something white here. This white thing, is it in the epithelium of the cornea? Is it in the stroma or is it in the back of surface of the cornea? It's on the back surface. We notice from here. It looks, this is the epithelium, this is the stroma. So this is either in the very deep layers of the stroma or on the back surface of the stroma. As you notice here, we get this white material So most probably this is something in the anterior chamber. This part I cannot tell is it superficial or middle or whatever, but I can tell about this one. Now in this another example, what do you see? I see some sutures here, so it looks that it's rounded all over, it's keratoplasty. Then we get this section in the cornea, and we have this membrane behind. So we get a homogeneous surface folding in the AC. Most probably this is detachment of the desmus membrane of this cornea. Here, just an example, we get here some iridectomy, and arrow is pointing here. Let's see what we're going to see. This is the section in the cornea, and you can see here there is some cyst. You see this is the wall, and notice the distance between this wall and the anterior chamber. If we make different sections next to each other, here there is some touch, one point touch, at the lower part there is no touch. So by changing the location of the section, we can tell exactly we get a cystic wall and it's touching the cornea in these locations, and it's away of the cornea on that location. What is the value of that? If, for example, you want to go with your instruments and you want to be in the anterior chamber, then you should start from this location. So this is the value. Now we come to a second thing, which is aqueous flare. Actually, this is a data projector in a dark room. I'm getting some cigarette to get the smoke of the cigarette to get this image. Is here, this is the cigarette here, and this is the smoke. So normally we don't see the passage of light, but if you get smoke in the way, light will be scattered from the smoke, then we will see the passage of light. I've told you we cannot see anything unless we get light scattered coming from that thing. And this is the situation if you want to see any floating particles in the anterior chamber. Normally the anterior chamber is filled with clear aqueous, like the air. But if there is particles in the aqueous, if there is proteinaceous material, they will scatter the light, then we will see the passage of this. This is an example of a patient. We want to see if there is any aqueous flare or not. This is the section in the cornea, and this is light on the iris, so this is the anterior chamber, and we concentrate here to see is the passage of light seen or not. If it's seen, then we say there is aqueous flare. To see the flare, certain things you have to do. First, we have to be in a dark room. I have to be darkly adapted for the sensitivity of my retina to be up. Then I want to increase the light to the maximum. I need to increase the light. I'm going to shorten the light of the slit beam, but not to the minimum, the shortest one. I will increase it a little step forward. Then if you want to get more light, I can widen the light a little bit. So it's not that short and it's not that narrow. A little bit longer and a little bit wider. In the textbook it's always written we have to check the flare away from the pupil. It's always written try to check the flare where you get the iris at your back to avoid what we call lens flare. Clinically I find it very, very easy for me to notice a flare in the pupillary area because the pupil is black. So actually, personally, I always check for a flare in the pupillary area, and I see stereoscopic, and I know this level is in the anterior chamber and the other one is back in the lens, so I can differentiate. So this is what I actually do. I get bright light, not that short, not that narrow, a little bit longer, a little bit wider, and see it in the pupillary area. And one more thing, if I start to move the slit lamp, if I hold the joystick of the slit lamp and move it from side to side, or if I elevate it a little up and down, then I'm going to test not only one location, but I'm going to test an area. So in my brain, I can get more information, and I collect these images quickly in my brain, and I can detect a flare. So dark room, highly adapted retina, bright light, not that narrow, not that short, in the pupillary area, and quick movement. Then you get everything to see a flare. Now in this example, this is the cornea, this is the iris, and this is the anterior chamber. I want you to notice, would you see any flare or not? There is some glue here. The passage is seen here. So this patient get an aqueous flare. This is against the iris, and if you go a little bit up, it will be against the pupillary area. You see, when the light is long, you can see better. If you are following a patient, we have to keep the same width and the same length for follow-up. You will say the flare is plus 1, 2, 3, 4, or the cells you've seen floating 1, 2, 3, 4. So you have to compare always the same length and the same widths. I'm going to show you some pictures. This is the first one, and this is a second one. What information you have in this image, and what information you get of the same patient but on the second image? What do you see? What? Epithelium. I cannot see the epithelium. Thinner of the cornea. This one is thin. Okay, this is the first thing. Depending on the angulation of the light, if the light is perpendicular, you will see everything end on. You don't have any thickness. But if you get an angle, the light coming with an angle, you see a thickness. I agree with you. So always we need light to coming from the side with an angle with the microscope. What else do you see? What? Heterochromia. Okay, it's apparent in either image. Yes, there is some elevation here. See the light and it's getting up. So there is an elevation here. You don't see it here. So the idea, if you get light end on, you will miss things. But if you get light coming from a side with an angle with the microscope and the source of light, you get a better information regarding the thickness. And if you get something elevated or depressed, you will see it better. Okay? Now we started by diffuse illumination, low magnification. Then we narrow the beam and make a section, and we notice different parts in the cornea or the anterior chamber. Then one of the things we can make use of the slit lamp is by doing what we call the indirect illumination. On the slit lamp, we get here some screw. If it's locked, it will make the focus of the microscope and the light on the same location. If you make it unlocked, you can change the light not to be on the same area of the microscope, but to one of the sides, not on the same location, but to either side of that location. You see here, I can move the whole band of the slit. This is the lock. This is locked now, so the light is fixed at this point. If you unlock it, you can change the location of the light. So in the indirect illumination, we need to do this trick. We need to unscrew this part to move the light to either side. I want you to see these two images. Here we see only, this looks like an iris and pupil, and we don't see anything here. But here you can see there is some ring here with dots in. This is a keratoprosthesis implanted in the cornea, this totally opaque cornea. In this image, you just see the cone, the part, the prism, the part seeing. But in this part, you can see this part of the keratoprosthesis embedded in the cornea. Here, the illumination and the microscope are focused on the same location. But here, we unlocked the light and pushed the light to the side here. So light scattered in the cornea, then you could see this part. So instead of focusing the light on the same location, put the illumination aside and keep examining the same area. You will see more things. Another thing is what we call the retro-illumination. It means that you are going to illuminate something behind to see something in front. Like here, light coming from back on the surface of this lake, and we can say that there is some lady standing here. We are not illuminating the lady, we get light from behind. Like here, this is the red reflex. We are doing light back and it's coming. What you notice here, you get some stitches. So this is the case of keratoplasty. Now notice the difference between this part and this part. As you notice here, we get some line and some dots here, and they are missing here. This is the rejection line of keratoplasty. This patient get a keratoplasty and get endothelial rejection line. You get KPs here, but not here, and this is the rejection line. It's very difficult to see, but with this type of examination, we call this a retro-illumination, we could see this. Another example here, we get some lines here, and what is this? This is the edge of the lens. Again, this is the retro-illumination. We are illuminating back and seeing something forward. Again, you can see here a reflection of the iris. You can see a red reflex here. This is the retro-illumination. Again, this is an after cataract, and this is the vitreous face. You get some injury here in the posterior capsule, but you see there is some membrane here and there. So again, this is the retro-illumination. We notice here some vacuoles or droplets. This could be in the cornea, this could be in the lens, it could be anywhere, but I mean, this is the retro-illumination. You get a red reflex coming from behind to see an anterior structure. Okay. Retro-illumination is not only the red reflex. We can have a retro-illumination to examine structure in the cornea against light coming from the iris. here. This is the section in the cornea, this is the anterior chamber, and light here on the lens. Now these lines, these are actual lines in the cornea, and we see these lines against the light scattered back from the lens. So these lines are seen, we call these lines seen by the direct retroillumination. And you see here, these lines are seen against black, nothing. We call this indirect retroillumination. Here we see some dots. Although the illumination is not at the dots, illumination is here. So this is a direct retroillumination and this is indirect retroillumination. Again, we can see here edge of these glasses, and also you can see this against darkness. Here you can see these lines. What does it mean? One of the tricks we have to do all the time while you are doing the slit lamp, you can unlock the screw that fixes the light under microscope, put the light a little bit to the side, and try to learn to see not only against the illuminated area, but next to the illuminated area. Now, what do you see here? A lot of dots here in the section, but also there are some dots here seen against the light of the iris, and some dots here seen against darkness. So this is direct retroillumination, this is indirect retroillumination. You can see all these dots. Okay? What about the iris surface? Is it the same here, this area, compared to that, the light you are seeing? Is it the same? So this will give me the impression that this part of the cornea is not as clear as this part. This is one of the ways to diagnose some edema or haziness, at least, whatever the cause of this haziness. So not all the time you don't have to concentrate on the section, but see around the section you are examining. What do you see here? We can see oval points all around. You can see them direct, indirect, and in this section, what is the level of these? It's endothelial. So these are ceratic precipitates, large ceratic precipitates. You can see them here in a section, and you can see them here on the back surface of the cornea. What do you see here? We see dots all over. These dots most probably in the cornea. You cannot tell the level unless I make a section. So it can be in stroma, can be epithelial, can be endothelium. Okay, this is an image of the pupillary area. This patient gets some cataract, and this is the same patient. So both shows cataract, but see the difference? This black thing is not that apparent here. This is an intralenticular foreign body. If the light is directly on the foreign body, we don't see it, as here. The light is locked with the microscope, but if we unlock the light and throw the light to the side, then through the retroillumination, we can see the foreign body better. So this is the idea. Now we come to another method of use of the slit lamp, is what we call the specular reflection. This is the idea of the specular reflection. Here we get the image of the sun on the surface of a lake, and this water is stable, while here we get some waves on this lake. This is the specular reflection, the reflection of light on a surface. Normally, we are accustomed to have this specular reflection when we are examining the cornea with the torch, the source of light. This is the reflection of light on the surface of the cornea. It's a homogeneous reflection, so the surface is homogeneous. While here the reflection is not smooth, what does this mean? This means that the interface between the epithelium and the tear film is not there. Either we have a dry eye and the tear film is not healthy, or the epithelium is defective. One of the two. This is the regular epithelial specular reflection that we are accustomed to do. If you want to check the cornea, you can have your torch covering the whole surface of the cornea to see the reflection. If the reflection is there all over, so you get a healthy tear covering the whole cornea and you get an intact epithelium all over. But if you get this irregularity in the reflection in an area, so this means that this epithelium is abnormal or the tear film is abnormal. Again, here in this image, the reflection is not the same, not like this one. Now I want you to see this video. I want you to concentrate in the pupillary area. What do you see here? The surface in the pupil. This is the surface of the lens. What do you see? Is it a smooth surface? Okay. This is a normal person, and what you have seen is the lens specular reflection. We call what you've seen what we call the anterior lens chagrin. It's a normal finding. You can see in any patient, a young patient, say 20 to 25, put him on a slit lamp and see the reflection on the anterior surface of the lens. I'm going to show you this appearance one more time. It's like the skin of the orange. It's an irregular reflection. Actually, this is the imprint of the anterior lens epithelial cells on the capsule of the lens. And this is a normal finding we can see in any young person. Clinically, we can check the endothelium specular reflection. To do it, you need to do the following. First, we ask the patient to look forward. Then we move the light to one side, and you and the microscope, the slit lamp, will move to the opposite side, so that light coming from the source of light will be reflected to your eye, and we should have angle of incidence and angle of reflection should be equal. So say 30, 30, 40, 40, whatever. The second thing is we need to get a very high magnification of the slit lamp. If you get two-step magnification slit lamp, go to the high. If you get multiple step slit lamp, go to the high. And again, if you get your slit lamp, sometimes you get slit lamp with extra eyepiece. Regularly, most of slit lamps get an eyepiece with magnification plus multiply 10. But you can, if you get an extra one, multiply 16, remove the 10 and put the 16. You will see better. So equal angle, incidence angle of reflection, and you get a high magnification eyepiece. And this is what you should do. You see, in this here, we get a reflection on the surface of the epithelium. I'm going to show the video again. I want to concentrate here when the epithelium is reflecting light. Here. If you go a little bit back, That's it. So this is the area I want to concentrate my examination. Here, this is the reflection on the epithelium. Okay, once I've seen this, I get a high magnification as I did here in this video. Then I will start to hold the joy of a slit lamp and put it a little bit in. So the focus, instead of being on the level of the epithelium, it will be on the level of the endothelium. And I want you to concentrate on this area. You will see the same appearance we've seen in the anterior lens shagreen, the pod orange appearance. Here, you see these fine dots? This is the normal endothelium appearance. It's the imprint of the endothelium on the desmus membrane. If you have a patient with endothelial dystrophy, then these dots will be large, not homogeneous equal. So this is the way to see the endothelium on a slit lamp. So one more time, if you want to see the whole video, we concentrate on this part. Once we see the reflection, we increase the magnification, push a slit lamp a little bit in, then start to focus on the endothelium. This is the appearance of the pod orange, the reflection of the endothelium here. Okay, now another video, another method. I want you to see what's going on here. You see the light is on one side of the limbus, but the opposite part of the limbus is illuminated. So in this method, we are not focusing the light on the same location of the slit lamp. We unlocked the lock that keep light and microscope on the same position, and we see what's going on. Here, the light is opposite. This is the normal eye. And in this side, this video, you can see there is some ring here inside the cornea, right? This is the case of keratoplasty. So this is the last method to examine the anterior part of the eye. We call it sclerotic scatter. So we unlock the knob that keep microscope and light coaxial. We put light on the limbus. The light will go total internal reflection between the anterior and posterior surface of the cornea to illuminate the limbus on the opposite side. If there is edema in this tissue, if there is some deposits in this tissue, then we will see this edema or these deposits better. Here, light on one side and the opposite limbus is illuminated, and we can see here some ring here. Again, light on one side, opposite is illuminated, and you can see some dots here in the cornea. So we call this sclerotic scatter. Why we unlock this knob? If you keep them locked together and put the light on the limbus here, your view will not cover whole surface of the cornea. That's all. So we unlock so we can throw the light at one side and still we can get the whole surface seen. So to sum up what I've said so far, we start by low magnification diffuse illumination, then we make a narrow section to make a focal section. Then while doing this, we see directly in the section, we see to the sides. This is the indirect retro and direct retro illumination. Then we can use certain things to see, say, reflection, specular reflection, the endothelium, or we can use sclerotic scatter. Some more things we can make use of the slit lamp is to use the slit lamp to measure things. The length of the slit light can be read from the slit lamp. We can have a long or short beam. You can read it directly. If you change the length of the beam, you can read from here how many millimeters is this length. Again, you can see that we can tilt the beam. Now it's vertical and we can make it oblique or can make it horizontal. So if you get something like this, you get a trigium, you can measure this trigium is getting into the limbus so many millimeters. So for follow-up, you can tell exactly is it stable or is it progressive. If you have a corneal ulcer, you can measure whatever meridia you want and write it down. So for follow-up, you can say this ulcer is improving or this ulcer is getting worse. Again, for the aqueous flare, we need to know exactly the length of the beam and the width of the slit. To know the width of the slit, you can get a wider or narrow slit and you can read the numbers here. So you can exactly know the width of the slit you are doing. Just one last thing is examination of the posterior segment. We can use either the 3-mirror, the Goldman 3-mirror, or we can use some of the lenses like the Volk lens or the pan-fundoscopic lens. All you know about this, we got 3 mirrors with different angles. One angle to see the angle of the anterior chamber, one mirror to see the equator or the posterior part, or directly you can see the disc and central area. One thing I want to show you is the tilt. If you want to examine the macula, usually slit lamps come with 2 mirrors. We get a regular mirror we use for the anterior segment. As you can see here, this mirror got a long part here. This is for the anterior segment. And there is another mirror missing this long part. This part is used just to examine the macula. So you take one mirror and put the second one. This is the slit lamp. I'm making this video using the regular mirror, the one with the long part. When I'm coaxial like this, the mirror hinder my view, this long part. I'm moving the light from one side to another. So when it is coaxial, I don't see the light at all. But if I put the short mirror, I can move the light from one side to the other, and all the time I'm seeing. So with this short mirror, I can have an end-on image of the macula. This is the value of the short mirror. You get what I mean? The long mirror, this part, if it's coaxial, the light and the microscope, this part will prevent me from seeing. But if I remove this part and I get just this short mirror, I can have the microscope and the light coaxial, and I can see through. This is just the idea of this short mirror. Now we need to make a tilt. We can understand tilt from sides. If you get a vertical slit, you can get the beam from the side 5 degrees, 10 degrees, and so on. But if it's horizontal, how to make this tilt? You see these steps behind? We can tilt the whole column of the slit lamp. This is totally vertical and this is angulated. Each step is angulated 5 degrees. So if I have a horizontal beam and I make this tilt, then the beam will come with 5 degrees to horizontal line or 10 degrees to horizontal line. So this is the idea of having this inclination of the slit, just to make the light not horizontal but coming from up, say 5 degrees or 10 degrees and so on. Okay, we get some filters on the slit lamp. This is where you change your filters. This is the regular light. This is the blue filter. And we have the green filter. This is the regular light. The whole spectrum is there with all the lights. If you use the red free light, this is the green light. We remove the red. We call this a red free. What is the value when we are going to use the red free light? When we are going to use the green light of the slit lamp? To see what? Nerve fiber layer. Okay. The idea, if you get a long waves, the long waves will penetrate tissues more. If you get a short wave, short waves penetrate tissues less. If somebody is tall and having steps, he can make a long distance in 3 steps. If you get a baby next to him, short legs, to move the same distance, this baby will move his legs, say 10 times. If we have a resistance for our passage, if this is not a solid ground, it's muddy, wetted ground, the long person get into the mud 3 times and he reach his goal. The short baby, the young baby, will start to move so many steps, so get so many resistance, so he will be tired quickly. This is the same. If you get the long waves, they can pass into the tissue and still they get the energy to keep on, while the short waves, they pass short period, then there is no energy, they cannot penetrate anymore. And this is the idea of using a short wave to see superficial structures. So the retina, if you want to see a lesion in the superficial nerve fiber layers, in the retinal nerve fiber layers, then you use the red free light. It will not penetrate to the choroid. It will still be in the superficial part of the retina. The cobalt blue, we use it for fluorescein. If you get an ulcer, I want to see it better. Fluorescence means that if you get some material to absorb short waves, this is the blue part, and re-emit it at a longer wavelength. This is what happens. You put a blue light and you see the green. The green is a longer wave. The last is the neutral density filter. The neutral density filter, it's a filter that affects the whole spectrum of rays. You can say, if I'm examining with a bright light, it will be injuring to the patient with marked heat. If I put the neutral density filter, it will minimize the whole spectrum down. So it's a way to protect the patient's retina and to make him more comfortable during the examination. Somebody may say, I can use the regular light and dim down the illumination. But this is not good compared to the neutral density filter for a simple reason. We've learned that if you stay in a garden and you start to see the colors of the plants and flowers while the sun is going away, then the colors change when the amount of illumination is less. Things like a red rose, just before absence of light, it will be brownish or dark. So this is the same. If you minimize the illumination of a slit lamp, the colors you'll see are not the same. It's not the natural thing. But if you put a neutral density filter, you get the whole spectrum and the colors are the same, but the amount of illumination is less. This is the value of the neutral density filter. So red free to examine superficial structures like nerve fiber layer, cobalt blue for fluorescence, and the neutral density will affect everything. Okay, thank you.